So, good afternoon. Thank you for joining us in this beautiful sunny day, a rare sunny day in Oregon in winter. Uh, it is a great pleasure for me to share with you my research and experience working in both teaching and research in healthcare system. So, what I'm going to share with you today is to have a systematic overview of universal healthcare system and also using example from Taiwan's national health insurance to illustrate the significance of having a national healthcare system, particularly in the pandemic, but still also important in the regular time. And at the lower right on the slide, that's the logo of the National Health Insurance Administration in Taiwan that I served multiple years as a consultant and advisor. So my talk is divided into four short sections. At the end of the talk, we will open up for open discussion. So the first section, I will introduce the topology of universal healthcare. And the second part, I will introduce some principle on finance and organizing universal healthcare. And the third part, I will introduce Taiwan, how Taiwan has become a very, very successful example. And in January, one independent organization, they ranked all the healthcare system around the world using a very comprehensive measurement of multiple indicators and come with a 100 score. And so with multi-dimension. And Taiwan came up as number one in the world. And I think if I remember correctly, US ranked around number 30 or so. And the last part, I will also talk a little bit about the barrier and challenge of organizing universal healthcare system. So let's start with the first one. So I always start with discussing about politics and science. There are science and politics on how we organize universal healthcare. First of all, the idea of having a universal healthcare is a pure politics because it's normative and it's value-based. And so there's a huge variation if you look at health system around the world. Particularly, I highlighted the values and goals. What should be the goal of a healthcare system? And each society's politics, culture, and norm will determine those values and goals. And the science come into play only after the society set the value and goal. And science help us to achieve using the method, scientific method to achieve those value and goal. Also, there are ethical framework for establishing a national health system. And here I only listed, this is not a complete list, just a common popular ethical principles. And I particularly highlighted the communitarianism is one of the core ethical principles that advocate or support universal healthcare system together with socialism. And the other ideology or ethical principle generally are against a universal healthcare system. And the nature of a health system and also the governance will determine who will have access to healthcare in the society. Also, who makes the most important decision, and the governance structure and process, and then who is accountable. At present, in the US, because we don't have a uniform national health system, so no one is accountable for our healthcare system. And it is also important to know the nature of the politics of the debate, policy debate, is because there are multiple perspectives how we can look at the healthcare system. And as an academic, I tend to look at healthcare system from a societal point of view. But in addition, people can look at healthcare system either as an individual, from the government, and the government's perspective are not necessarily aligned with societal. And so academic And academic are not necessarily also aligned with societal, because some academic can be taken purely from the purpose of knowledge point of view. And then there's a health professional, provider, organization, insurer, health-related industry, laborers and unions, and investors. And many of those perspectives are in direct conflict with each other or competing with each other. And that also leads to the key question: what is the goal or the function of a health system do? The first three are quite intuitive: provide healthcare services, preventing disease, and promoting population health. And then I highlighted these three. These are from the earlier I mentioned the communitarian perspective, the principle: promote equity, solidarity, and a caring society. And Bob Evans mentioned about nation building as an example. And we had a precedent in 2003, after the second Iraq War. The U.S. was involved in not a nation building, but a nation rebuilding. At that time on the table was a universal health care for Iraq. And that stimulated a lot of discussion. So a system is good enough for Iraq, but not good enough for the United States. And then there are other potential functions: sense of security, pain relief, hope, but also comfort, convenience, and then providers' income and job, or investors' income. And one of the big barriers in promoting universal healthcare in this country is focusing on here: the providers' income and job and investors' income. The WHO, since the beginning of this century, has been advocating universal health coverage, and that's the WHO terminology. They use that term, USC. And it highlighted three major principles: equity in access to health services, and quality of health services should be good enough, and people should be protected against financial risk. And anyone who is interested, you can go into more detail. There's lots of documents, lots of material and references in WHO website. And this is one of my favorite chart to explain the variation in national health system. So I use a very simple two-dimension, and I need to give credit. I'm not the one who invented this scheme. I'm the one who organized it from my graduate school advisor class, Professor William Shaw. So I organized this chart from the lecture note I wrote down when I was in graduate school. So there are two dimensions we can look at how country organize healthcare system: finance dimension and delivery or organization dimension. And this was simply use 2 by 2. Keep in mind, there is no clear cutoff line. But between public and private usually is a continuum. And so when we look at the upper left, we have a finance and delivery primarily in the public sector. In academic world and literature, there's a terminology for that. They're called national health services. And the classic example are from particularly UK. I listed those examples in alphabetical order, but most well known is from UK, but also Scandinavian country. And prior to 1990, all communist countries also had this system. The second one, this is by far the most popular system in the world, where you have public finance predominantly, but the delivery is primarily in the private sector. And the academic term for that is called national health insurance. In the US, we tend to use the term single payer. But single payer is a very exclusive term. It's just one type of national health insurance. So the national health insurance indicate is predominantly public finance, but private delivery. So this is a more inclusive term in which single payer is one of the popular form. So there are most high-income country, including Taiwan, Japan, South Korea, and many emerging economy in the middle-income country, they all belong to this category. And the third category, I call it transitional because this is a very weird system. No country is in this category by design. All the countries who are in this box, this category, were forced by the circumstances. For example, all the former communist countries, and there are still a few present communist countries, such as North Korea, Cuba, only a few left. They used to be here. National Health Services, everything financed and delivery by the government. But after 1990, when most, including the former Soviet blocs that broke into 18 republics, and then the Eastern European countries, they also simultaneously, most of them kind of dissolved their former health system. And many of them on paper or even on their constitution, they still have the National Health Services. But we meaning the academic, put them here. Why? Because the classification is not by what a country claims, it's by what is actually being done. So many countries who would claim they have NHS, but in fact, because their government no longer are able to finance enough, so the vast majority of finance become private. Many of them informal payment. That's why no country is here by design. They're being forced into this box. Also, there are quite a lot of low-income countries, particularly in Africa. They also have this system. And so they claim that's on paper, but in practice, they're here because of the lack of funding, lack of resources. For example, a very typical phenomenon in many low-income African countries is you go to a clinic that is public. The consultation is free. But if you need suture, need surgical material, need drugs, they don't have. You have to buy from outside market. And that's how they become here. So all the countries who are here, they don't want to be there. They want to move away from here. Some of them, if they could, they want to move back to what they claim they are. But many of them are moving towards here. Czech Republic was the first Eastern European or the former communist country that moved from here to here, from NHS to transition. And then by 1997, 98, they moved to national health insurance. And then the last one is market-oriented. That's represented by the United States. And when I teach health system finance for my graduate classes, I always tell my students that do not use the popular term here in the US, so-called socialized medicine or socialized healthcare system, because that doesn't tell much. Because if you call socialized medicine for any health system involving government, then we pretty much have about more than 95% of the world's healthcare system. In this box, they are all socialized medicine in different way. And so this is a more specific and more clearly and well-defined classification. Next section, I will look at into the particular finance and organization. So using the previous classification, this is the reality. I mentioned the public-private. So the positive side is the strength of public involvement. So in delivery and finance, and the zero means the private system. So you have two extreme corner. On the upper right, you have a complete public finance and provision. On the lower left corner, you have a complete private system. And where we have something close to here, but we never seen this. This is just in theory they could exist, but in reality they never exist. The vast majority of the country probably in the middle. And the national health insurance is you largely have a public finance and private delivery. And this is the more technical definition I will not get into too much of that technicality, but just to share with you the nature of the finance of a universal health care. They could come from government domestic revenue, and we have an example in the US. Our Medicaid is financed through this form. And then the second source is social insurance. And we also have example, our Medicare is a form of social insurance. Except our Medicare and Medicare, they are not universal. They're just for a partial category of population. And then the compulsory prepayment, other than the social insurance, there are a few countries, they have a mandate, everyone must buy health insurance. And for a while, we have a little bit of that. The Affordable Care Act is a form of this compulsory prepayment, except again, that's not for the entire population because it coexists with Medicare, Medicaid, and private insurance. So the last category is voluntary prepayment. That's the private insurance. So in a way, if you look at those four major forms, the US has them all. We have Medicaid, Medicare, the Affordable Care Act, and then the private health insurance. Let me focus a little bit on the public finance of national health insurance, universal health care. So the general tax revenue is one common source, such as our Medicaid. And our Medicare is also partially financed by general tax revenue. The earmark tax, our Medicare is financed through the payroll tax. Many countries' national health insurance also use this form, the payroll tax. But Canada's national health insurance are largely financed through general tax revenue. And then some countries also supplemented with special taxes. And the mixed tax meaning a mix of many types of taxes together. This applied to only a few countries where they have a big public enterprise revenues, such as Norway and the oil producing country, Venezuela and Saudi Arabia, Kuwait, etc. And their public enterprise generate lots of revenue that can help finance the universal health care. In terms of financial burden and distributive justice, even though the distributive justice is a normative issue, the most nations that implement universal health care tend to apply the so-called ability to pay principle. By ability to pay principle, it means a progressive taxation and income-based, not based on utilization or health status, meaning people who generate more income contribute more. They also tend to limit private finance and out-of-pocket payment. In terms of organization and delivery, for the national health insurance, they generate a public-private mix, and different country has a different allocation of what percentage public, what percentage private. There's also variation in whether the country allow for-profit or not. The vast majority of Western European countries forbid for-profit hospital. And also the variation in the role of primary care, or sometimes we call gatekeeper. Again, different countries have variation in patients' direct access to the secondary and tertiary care. This is the latest data I just found out yesterday as I was preparing for today's talk. The data from 2019 and shows US and other high-income country comparison. OECD is an acronym for high-income country. There's a little bit over 30 countries in the world belong to this group. So we are an outlier in terms of total spending. And the blue shade is the public sector spending. The light blue, the dark blue is out of pocket. The orange is private spending. So if you look at our private spending, it's the same or exceed the OECD total average. And also our public spending alone also exceed the OECD average. And our private spending constitute a high percentage of our total. And these are the countries that has universal health care. That you can see their public spending constitute the biggest chunk of their total spending. In the next section, I will introduce Taiwan as an example. Taiwan, the area is only about 1/7 of Oregon, using Oregon as a reference. But the population is about 6 times of Oregon. And this is the evolution of Taiwan's public health insurance. They started with labor insurance that cover private employee, but not their family. So this insurance covered about 40%. And then the public employee insurance, that also cover their family member, altogether 8.5% of the population. And then by 85, they added farmers insurance, that's cover 8.2%. And then a little bit of the low income household insurance. And from 1988 to 1993, so a little bit over 5 years period that Taiwan planned for this national health insurance, the legislature passed it in 1994, and started to implement in March 1st of 1995. 2010, they did a financial reform they called second generation, and that implemented in 2013. So this is a quick summary of the nature of the NHI. Compulsory enrollment for all citizens and legal residents, that means visitors who stay in Taiwan for 6 months or longer, are required to enroll. So Taiwan's system is a single payer. The financing, including payroll tax and special tax plus general tax. The benefit is uniform across the board. Everyone have the same. And the provider are contract based. About 93% of the nation's provider are contracted. And they have a complex payment system, but with the global budget as the main framework. And there's also subsidies and waivers for low income. And it has a very comprehensive benefit, and even cover the Chinese medicine. And let me summarize some of its achievement. It improved population health. There has been lots of empirical study comparing before and after national health insurance. See how the overall health indicator has improved. And it achieved universal and comprehensive coverage for everyone and equal access for everyone. Also improve equity of financial burden in healthcare. And it implemented very effective cost control with very low administrative costs. And few countries' healthcare system have received such a high approval rating persistently, 80% and higher of the people who are satisfied. And the government has been very sensitive in public response. Ever since the first year of implementation, the government has tracked, they contracted with public relations firm to do the seasonal, the quarterly survey. So they track the approval rating every 3 months since 1995. And it implements public accountability and input. And patients have complete free choice to any level. There's no gatekeeper system. And it integrates health care with public health, which later I will comment a little bit, become very critical during the pandemic. And the national health care population data also stimulated more research. And now they implement the latest big data technology and analysis to further improve the quality of care. So this is the quarterly tracking. And there have been some dip in even when there was some dip, there are still about 60% or higher public approval. And in recent year, it has been more than 85%. The latest was 89.7% support or approval. So they track from 1995 and continue. And my colleague in Taiwan also did the analysis of equity in financial burden. So they look into 5 income quintile and they measure their tax burden. So the bottom one is the top 20% income group. The top one is the lowest, the bottom 20% income group. So my colleague, they measure based on the benefit you receive, converting into monetary value, and divided by the tax contribution you contribute. So this is the result that the lowest income group, they benefit most. That is the benefit they receive divided by the tax they contribute. They receive the most compared with the highest. So the ratio, when the ratio below 1, meaning you contribute more money than the benefit you receive. So that result in the highest 40%, this the highest 20, the next 20, the highest 40% group, they are subsidizing the other 3 groups. So that's the equitable financial burden built into the system. And this was in 2016, the British-based newspaper did an assessment of a large number of countries' healthcare system, many high-income countries, and put Taiwan as a far corner of its own. So with the best quality and highest affordability, that's Taiwan. And US is here, very low affordability together with Switzerland, but Switzerland has better quality. And US has both low affordability and low quality. And this came out just January this year, the latest. I mentioned an independent organization using a very comprehensive indicator to measure 2 dimensions, the general health care and healthcare expenditure. For the general healthcare, I think the total point is 100. The healthcare expenditure, the total point is 200. And Taiwan ranked number 1 in both dimensions, have the highest. And I think US ranked about number 30. So here I have only the top 20. So Taiwan's national health insurance also implement lots of innovation, quality-based reimbursement, global budget, the IC card. Every member has a smart card, and it provides real-time information for provider and NHI administrators. It also provides online claim submission. Taiwan was the first nation to achieve near 100% online claim. And that also benefits providers. They can receive payment much, much faster. And the health information technology, MediCloud, it was designed to improve quality and reduce waste. But during this pandemic, that information technology become very critical health information technology for pandemic control. And most recent addition is called My Health Bank. That individual with their IC card, they can have access to their entire health record history in the cloud. So this is the NHI card, an example of with the IC chip. And it also does infectious disease tracking and monitoring. For people who are under quarantine, or we also have a stage for self-health management. All visitors to Taiwan are required to do a 14-day mandatory quarantine, followed by a 7-day self-health management. During that 7 days, you are not allowed to go to clinic or hospital unless emergency. And you are not allowed to go to public places or use public transportation. And they track your cell phone signal. And so I have friends who did not know that part of regulation. After quarantine, tried to go to clinic, and when she stick in her national NHI card, the hospital told her, no, you're not allowed to enter because you are still under the 7-day cell health management. You're allowed to enter hospital only for emergency. So that played a very important role in pandemic control. And this is the Medicloud system that started in 2013 and completed in 2018. And that's perfect timing, just in time for the use to be used in this last year's pandemic. It served multiple functions that even helped. By February 2020, Taiwan was the first nation in the world not only have universal healthcare, but also have universal access to surgical masks. They ration surgical masks to everyone using the same platform, the medical system. And that medical system is accessible by every individual through this portal called My Health Bank. And it also has a cell phone app. And I've been showing this chart a lot by now. I have done over 20 webinars on the pandemic. And this is the daily new cases in Taiwan, the COVID-19. So Taiwan's population is 23.8 million. Frequently, when I show this chart, the moderator or the audience always ask me, what's the unit here? Is that in 100 or in 1,000? I said, no, that's the actual number. So Taiwan never had any single day since the beginning of pandemic in which the daily new case exceed 30. And so as of February 25th, with 23.8 million population, they have a total 951 cases. And of this 951, the vast majority were imported and they were quarantined. Only 77 were domestic. And the total deaths, 9. And between April and December 15, there were 247 consecutive days with no single domestic case. So the epidemic control success result in no community outbreak, over 8 months without any domestic case, low case per million, deaths per million, high recovery rate, and remarkably, never locked down. And everything remained open. I really envy my colleague in Taiwan that they always teach in-person classes. They get to go to in-person conferences or give an in-person seminars. And that minimized the damage to the economy. At the end of last year, Taiwan has one of the world's highest economic growth, positive 2.7%. The vast majority of countries, including the US, suffered a negative economic growth last year because of the pandemic. And that's a population effort and support. So this is a quick comparison of US, Australia, both a big continent, and then Vietnam and Taiwan. These 3 countries are relatively successful in pandemic control compared with the US. So this is the total deaths across these 4 countries. And adjust for population, this is a case per million. This is US, over 86,000. Australia, a little bit over 1,000. Vietnam, 24. Taiwan, 40. And then the deaths per million, US is 1,500. Australia, 36. Vietnam, 0.36. Taiwan, 0.38. And the current daily new cases within last 14 days, US is 160. This is per million. US is 167 to 392. Australia, 0 to 0.4. Vietnam, 0 to 0.5. Taiwan, 0 to 0.2. And this in terms of the economic decline. US is here. This was last year's second quarter. And Taiwan is here. And this is the latest statistic on from the Google big data, because Google can track the users, how mobile they are, their geographical information. So on the upper right corner is high mobility, high recovery. So Taiwan, Vietnam is right here. And US is here, that representing relative low mobility and low recovery. Last November, the Phantom of Opera from Broadway traveled to Taiwan, and the whole crew went through 14 days of quarantine. And after quarantine, they did a live performance in front of live audience. Not many places on earth can do that. And they did that in Taiwan, in Taipei. On December 31st, Taiwan had the world's largest crowd gathering to celebrate New Year. This largest one, a New Year concert, attracted over 70,000 people. They're shoulder to shoulder. And Taiwan is probably the only place safe to do that. So I summarize the role of a national health system in pandemic control. It provides healthcare infrastructure, mobilization and integration of healthcare resources, and assurance of equitable access to prevention measures such as mask, tests, treatment and care, and vaccines. And of course, this pandemic demonstrated to us an inconvenient truth for those who are not for universal health care, that private healthcare system is incapable of handling pandemic. And also provide the health information technology for pandemic control. And most importantly, is a social institution to enforce solidarity and social well-being and public trust. So the last section, let's look at some barriers. We have this debate of consumer. Are we treat individuals in healthcare as consumer or citizen? As consumer, we emphasize individual freedom. As citizen, we emphasize societal freedom. And I'm going to show some of the comparison. This is the administrative cost across high-income country. The US has the highest administrative cost. And healthcare spending. So in 1980, US was not that much of an outlier. But since 1980, you can see how US departed from the rest of the high-income country. And given our spending is outrageously high and outlier, it didn't buy us much. This is the chart comparing hospital bed per 1,000. So US is here. Compared with the other rich country, we have much less. We are below the OECD average in terms of hospital bed per 1,000 population. And likewise, we didn't provide much hospital care. This is the population-based average length of stay. The US is much shorter. Likewise, our outpatient consultation are far less than most other high-income countries. And our population is not much older than other countries. So the orange is the percentage of population who are 65 to 79. Blue is the percentage of population who are 80 and older. So compared with other rich countries, we are actually relatively younger. And half of US adults with lower income skip needed medical care or did not fill prescription drug. So US is here. And the darker dot is high income. Even the US high income are not faring much better for other countries' low income. Similarly, had problem paying medical bill. 36% of US low income people have problem, but even high income, 9% of US high income population have problem paying bill. And talk about access. There's a myth about having universal health care will keep people in the waiting line. But if you look at the problem of access same day or next day, for the high income US population, only 57% of the high income have access. And that's actually worse than some of the low income people in other countries with universal health care. And of course, the low income have much less. And compared with other high income countries, we have the highest preventable deaths per 100,000 population. And in a similar statistic, comparing one decade between 2004 and 2014, the US has the highest mortality that amenable to healthcare, meaning if people, the measurement of this is if people have access to healthcare, they don't have to die. And US has the highest. And this is another comparison on performance versus spending. And again, US shows as an outlier. And this is healthcare index by country in the world. The common challenge in universal health system on the political dimension, lack of solidarity and sharing capacity. On the technical side, it ranging from quality improvement, cost control, improving access, etc. And when we assess the success of a national health system, we have to ask success in what? And these are the common measurement for quality and success. But one that's seldom measured is, are we achieving a better society for all? And this is the quote from one of my mentors, Professor Will Reinhardt. He was invited to give us presentation on the 20th anniversary of national health insurance in Taiwan. And he said there's an issue of economic versus political sustainability. Healthcare is sustainable as long as it is not wasteful. And he argued waste is sinful. So our future lies in, are we going to have an emancipatory or colonized health system? And this is my concluding comment on the 2008 Oregon Health Forum. I said a country's healthcare system tells us about the nature of the people in the society. And two quotes from my other mentors, Governor Mooney. He said, what sort of healthcare system do we as a community prefer? And this is determined by what sort of community would we prefer to live in. And that concludes my presentation. Thank you very much.
Thank you, Professor Chi. I want to particularly thank you for the way you finished up, since many of us are here because of our involvement in this issue, because of our faith. That last part was very powerful. We're at 151, and I'm wondering, I'm sure people have a lot of questions. I'm wondering if you, Professor Chi, and if our host, Tim, have time to stay a little after the hour?
Yes.
Tim?
Yes.
Thank you. Okay, I'd like to open it up for questions then. If you can stop screen sharing, it will be easier to...
Yes, I will do that.
Thank you. I'm trying to figure out if people are using... Let's see.
Yes, I just stopped screen sharing.
Thank you. Okay, so it looks like everybody's on the screen. If anybody has a question, you can either raise your hand if we can see you, or raise your virtual hand by... No questions. Wow. Okay. I wrote down a few. June, did you have a question?
Yes, I have a. Can you hear me?
Yes.
Yes.
Okay. How do we get a system like Taiwan's in the United States? what would you suggest, having worked here and been in both places and knowing our weaknesses and our strengths as a country? How would you suggest we go about this? Because we have not been successful in bringing it about, even though the majority of the people in the United States would like a universal system.
That's a big, good, and complex questions that we are all struggling. No country's healthcare system is coming out of the blue. All countries' healthcare system went through its historical, cultural, social evolution to get to where they are. And at present, we are for the United States. By the way, I have been volunteering for the Mid Valley Healthcare Advocate since 1997. So it's been over 2 decades. So I have been follow all the trend, and also volunteer for other group advocating universal healthcare either here in Oregon or for the nation. So I'm very much aware of all the barriers. And I would say right now we have both the worst social climate, but also the best opportunity. The worst social climate is the United States has never been so divided that since the last administration. And that's the worst social climate. And I mentioned one of the key social value to facilitate, to promote universal health care or accommodate universal health care is sense of solidarity. And right now, that's the worst condition for the over the last 2.5 decades. I have been advocating for universal health care. But at the same time, we also have the best opportunity. Unfortunately, this best opportunity is also the worst pandemic we ever experienced. And I mentioned in my talk, the pandemic exposed the extreme limitation of what a private health system can do. It also exposed the severe weakness of the US fragmented healthcare system. And it not only prevented us from engaging a more effective pandemic control last year, it also hampered our ability and effectiveness in rolling out vaccination. Not just in Oregon, but across the country. I have read so many reports, so many stories, how chaotic the rolling out of vaccination has been. And that's to be expected, that since we don't have a uniform national healthcare system, and on top of that, we have a weakened public health infrastructure. When you put two together, what else can you expect in terms of the rolling out the vaccination? And so those pandemic-related issues expose the urgency of having a universal healthcare system. So those of us who advocate, who want to promote universal healthcare, we need to take this opportunity. But at the same time, we also facing that extreme barrier of a very divided society. And in a very divided society, it's much harder to obtain solidarity. So one strategy in terms of both in the legislative work as well as in the grassroots work is to advocate the issue of on top of the pandemic recovery, the healthcare does not recognize whether one support Republican or Democrats. It affects everyone equally. But again, there's a barrier because there's a sizable percentage of population within the Republican camp to this state still follow their leader to claim this whole pandemic is a hoax. And I have graduate student told me who come from rural community, and she told me her entire family, relative, and community member belong to the pandemic denier. To this day, after 500,000 Americans died, they still don't believe there's a pandemic out there. So that's yet another barrier. So hopefully, that proportion of the population will continue to decline. And that will be the opportunity for us to communicate effectively why it is in everyone's best interest to implement a universal health care. So the issue of promoting universal health care in the US is not in the technical side, it's in the political side.
Yeah, I was really struck by how fast Taiwan turned out their system compared to how long we've been struggling to get it in the US. It'll be very interesting to see if our task force here in Oregon comes up with a system that we can implement in a year. Not likely, but it'll be interesting to see how long it will take. Other people have questions? David.
You're muted.
Okay. Question about the rollout of Taiwan's system, its single payer system. Beforehand, how big a share of the healthcare money was controlled by private payers? I see that obviously in the United States, our big problem is that the insurance companies have more money than God. And when we try to go to a single payer system, they're going to use that money to fight us tooth and nail. Like it's going to come to a vote, and they're going to buy up every minute of television time going into the vote. Was Taiwan's private pay system as strong before it went to single payer as ours?
No, that's fortunately. Prior to 1995, Taiwan's presence of private health insurance was negligible.
Uh-huh.
So Taiwan did not have that hurdle to overcome. But at the same time, Taiwan learned from Canada's experience, knew the potential threat, because within 4 years, actually 3 years, by 1998, there were lobby in the legislature want to privatize the national health insurance. And so Taiwan from the beginning, in part of that legislation, the legislation that passed in the parliament to implement national health insurance banned private health insurance. And they found the loophole. The private insurers found the loophole. So you cannot sell standalone health insurance, private health insurance. But you can sell that as a package, as part of life insurance. So Taiwan's government fight that by continue to expand and implementing very generous coverage. So that heavily squeeze the space that private health insurance can operate. So what private health insurance can do as a supplement, and they sell that as a part of the package of the life insurance because they are not allowed to sell it as standalone, is to help you pay the cost sharing. So the only benefit to have supplemental health insurance is helping you pay the cost sharing. It doesn't give you additional health care benefit.
Okay.
Thank you. I believe Linda had a question next. You're muted still? Hold down your space bar, Linda.
Okay.
There you go. Well, keep it down. Hold it down and keep it down.
Okay. I was wondering, what are the factors that contributed to the ability to socialize in such big crowds and so closely? I mean, with the pandemic still going on.
Well, that's simple because since April 12, Taiwan no longer had any domestic cases. So recently, I was interviewed by a Swedish national TV, and they produced a documentary, 28 minutes documentary, and the title, the title for that documentary is, quote, "Virus-Free Taiwan." So when you don't have any domestic cases, you can do anything. That's why the Broadway Phantom of the Opera, they could perform live in front of live audience in Taiwan. That for years they can't. And for another half year, they won't be able to perform in the United States.
Thank you. Jana had her hand up. You're muted too, Jana.
Your presentation was loaded with information. It was so informative and striking. I'm wondering whether this presentation has been available to the task force that the legislature has established to deal with funding, and also whether you have had any access at the national level to administrative healthcare thinkers.
The Oregon Task Force actually invited me to give a presentation for them last July. So I did a shorter version of this presentation for the task force last July. And for your second question, no, I don't have access to the national level policymaker.
If I may say so, it's time for the task force to invite you back for a fuller view, particularly because what happened, what all the things that are in your cloud and the things that have prevented the virus from spreading and killing in Taiwan is just amazing.
Maybe present to Biden.
Professor Chi, because this was so informative, I was wondering if you could send me the slideshow so that I can send it to people who are attending.
Sure. And I think it will be even more useful when you share the recording.
We will post that, yes. And I will try to remember to go back to it once it's posted and get that out to everybody. Thank you for that reminder. But I'd still like to have the slides.
Sure, I will. I will share with you.
Great. Well, I am going to put my email in there for anybody that's not on one of the email lists where I send out invitations. Send me an email and I'll make sure you get it too if you want it. But otherwise, I'll send it out to the email lists I use to invite people. Other questions? Well, I had several, but I don't know how long I want to make Tim stay here and you, Professor Chi. Let me just ask one that's nagging at me. Maybe it's just me, but I was a little confused when you showed the slide that distinguished between private spending and out of pocket. I'm not sure I understand the distinction, and apparently it's an important one.
Yes.
Because private spending is where the big jump is.
The category of private spending is largely private health insurance. And then the out-of-pocket payment, that simply means people have to pay out of pocket. And that, for the United States, does include the cost sharing, either private health insurance or Medicare, Medicaid.
Oh, so it's the premium cost. I gotcha. Okay. I guess I was thinking of those as out of pocket too.
No, the out of pocket is a separate category.
Sure. That makes sense, actually. Any other questions from anybody else? I'll sneak one more in here then. Can you comment on the effect of not having gatekeepers? I'm sure that a lot of people are wondering how you keep costs so low with no gatekeepers.
Yes, that's a good question, and an issue has been heatedly debated in Taiwan whether Taiwan should implement a gatekeeper system. And I have been serving as an advisor or consultant to the National Health Insurance Administration, and they also consulted me about this. And this also has to do with the culture and norm. And I always said the Taiwanese people are being spoiled, that they can tolerate a gatekeeper. They just want to have the complete freedom to access any level of healthcare. And so my colleague in the National Health Insurance Administration, the strategy they did has been to increase the cost sharing if you go to a secondary or tertiary hospital without a referral. But that still has very little effect in preventing people from just go straight to the teaching hospital for just a very minor conditions. And the reason they can keep the cost low was partly the whole system was running extremely efficient, and also partly the payment system and the monitoring system has been relatively effective in controlling the cost inflation. That's why in one of the charts I showed, Taiwan is not only #1 in overall healthcare index, but also #1 in healthcare spending index.
Well, I am not going to hold everybody here because I have questions. Maybe I'll email them to you.
Could I ask one more? Could I ask one more, Rick?
Yes.
Sure.
Since Dr. Chi knows Oregon well, and we're many of us are working on a state initiative, what are your suggestions with the issues surrounding money and abortion?
Are you talking about, are you referring to if we implement a universal health care, should our universal health care include abortion?
Yes.
Yeah, that's a very hotly contested issue. And personally, I would like to see it covered, but I know in reality, that will face a fierce resistance. And so I don't have any strong opinion on how to fend off those resistance. And I'm just saying my personal preference is to have that included. Yes.
David, you're muted.
Okay. I do the occasional presentation on healthcare to especially church groups and labor groups, and I tend to avoid the abortion issue. But the analyses that I've gotten shows that countries that have universal health care all have lower abortion rates than the United States does.
Let's hope that's cause and effect. It would be nice to lower that.
Well, one consideration is that if one had universal health care, a lot of people who have been left out would probably carry to term knowing that they wouldn't be facing a horrendous bill down the road.
Yes.
Makes sense.
Also on top of that, most countries with universal health care also cover family planning services. And that remove or significantly reduce the opportunity for abortion.
Exactly.
Great points. Any other questions? Okay, well, I promised I wouldn't ask all my questions, so I guess that's it. And I really want to thank you for an excellent and informative presentation, Dr. Chi. That was
Thank you. It's a great pleasure. Thank you.
fantastic.